Good. Okay, well, I'll just thank everybody for their time because I know it's the fifth Tuesday and really appreciate your being able to Zoom in and take more of your own personal time. Um, I don't know if everybody's had a chance to look at the agenda and think through some of the questions that came on the agenda. But the first thing that we wanted to talk about is just trying to optimize the use of Practice Fusion. And so I've been working with Jefferson Lab to see if we could have the lab results loaded into the EHR. So that's a work in progress. It's going to take a while if it can be done because their IT department has to kind of study us and see what the volume is and see if they already have Practice Fusion set up, for other practices, then it would be easier. So I'm not going to hold my breath on that, but that's one thing I would like to see happen. And then Lacey and Carissa and I have been playing around with Practice Fusion to see other ways that we could use it to kind of consolidate information so that we're just accessing one thing and not multiple different systems. And one of the things we've been playing around with is the task feature. So I think Lacey's going to share her screen and show you all how that works. And then we can think about how we would hope to be using it.
Yes. So I will share my screen. So everybody can see Practice Fusion?
Yes, I can.
Awesome. Great. So when you first sign into Practice Fusion, it looks something like this, right? With like the little boxes in the middle. And then on the left, we've got home, schedule, tasks, charts, messages, reports, and subscription. So if I go to tasks, I just click on the third one down. If I have any tasks, they will appear in this area. Now, you can see on the left, it's the name of the task, reminder, and who the task is for, the patient, and information about the patient, and then the details of the task. So how would you create a task? And we'll go over why later. So say I'm seeing patients, so I'm going to go to a chart. So for example, I'm going to go to Bob Berger's chart. He's a pretend patient, right? So I'm at his chart and I've just seen him and I want to see him again in 3 months and I want XYZ labs. So what I would do was I would just press the buttons NT for new task, and it just shows up on the page. So I would think if I want a new task, NT, shows up. I would write follow up in 3 months, labs week before, CBC, A1C, hepatic panel. And then I could say, for example, like hepatitis shot, or no, I guess you're getting the hepatic panel, so maybe not. Flu shot, there we go. When available. And then let's pretend Bob's a woman, mammogram. So all of the information that you would normally write on those pieces of paper, maybe EKG, whatever it is that you want to convey to Patty and to future appointments to get this information across. Because you guys might remember we used to have future appointments, right? So the idea is we're trying to bring back future appointments, but we're trying to make it easier for everybody and also still create the quote unquote paper trail, but it's going to be in Practice Fusion. So I've filled out the information that I want, everything I want future appointments to know. Now I have to do the assign to. So I'm going to assign it to Future, or is that what it is? What's your account called, Carissa?
It's appointment desk.
That's what it's, appointment desk. Thank you. Appointment desk. So I assigned to appointment desk. It's already got the patient, Bob Berger, and that's all. I don't have to do anything else. And then I would just hit save. And then Carissa is going to get on hers a task. So I've sent one to myself earlier. So here's an example. So all she has to do is now look at this, and she knows exactly what you want. And so she can make sure that they get their appointments. She can make sure that they're getting their immunizations, all that jazz. So again, if I'm at the patient's chart, all I have to do, I'm at the patient's chart or in the SOAP note, anywhere, all I have to do is type in NT, push both buttons, NT, and a new task appears.
Could you show me that NT where that new task?
Yeah, so it's, you know how on your keyboard, you have the letters?
Mm-hmm.
You just press the N and the T letter at the same time.
Oh, that's all you have to do?
Yeah,
Okay.
and it works from anywhere in Practice Fusion. So
Oh,
it's
that's great.
easiest if you do it from the patient's chart, because then
Mhm.
all their information already comes up, but you don't have to. You can be anywhere in Practice Fusion.
Mhm.
It's also available as an option if you go to the actions up in the right upper corner and
Oh, I see that.
that
Yeah.
little arrow.
Mhm.
It's a new task is somewhere down there, right
So
there.
you can get it. Yeah, I can see that. It's probably
Yeah.
create task. I see its task.
Yes.
Yeah. That's good to know too.
Mhm. And so the idea is to send it to future appointments and just one task with everything, your labs, your appointments, immunizations, EKGs, everything. Any other questions?
Does that seem doable?
It does. And then you can put, EKG will come up so that it's known that that will be done on the next visit.
And could it be done before the patient leaves the room? So Carissa, who is working on future appointments, knows what to do that day. For example, like if a vaccine is in there, then she
Right.
would route them to the vaccine spot.
Right. But the EKG could be done definitely ahead of time. If that's doable.
Mhm.
Could be done either or, but
So maybe
before will
EKG
work.
needs to be qualified, like EKG today or EKG at next appointment.
Hmm. Well, if that's going to be in the chart someplace, that will be nice. So that's sometimes, we'd have to look through the papers to see when the previous EKG was done. But this way, if it's somewhere where you can see it easily on the, on the chart, our electronic chart, then we'd know when a year is, if we do it annually, or that would be a help.
Well, that we always
But we
upload.
could put in one on the next visit. Usually when I write it in the plan, it's hopefully the next visit or sometimes that night, but maybe that would be best that, because you never know if there's enough time that night, just, quickly. So it's best probably if it's in the task bar.
The other thing is you can task other people. So for example, if somebody needs a diagnostic mammogram, that should probably get tasked to me so that I can work on, a whole different mammogram system than
Mm,
Carissa, who's putting it on the mammogram ban list. But if it's something that, needs medical attention, you can task anything to anybody. even, a different provider, as long as we're all looking at our task list. So, I mean, Carissa and I plan to work off of the task list rather than the paper that comes back to the office.
Oh, right.
And if you forget and you task it to Carissa, she knows like mammograms go to Patty, and she knows
Okay,
EKGs go
so
to Patty.
Patty or Carissa.
Yeah.
yeah.
So if you don't remember and you just send it all to the same person, it'll get sorted out.
Mhm.
Right, so Carissa can forward it on to me and vice versa. I can forward things on to people. And you can also kind of keep track of where you are, like maybe you made the future appointment and put in the labs, but didn't do something else. So, we can add to that and write in that and write messages to other people. So
Carissa, was there anything about tasks you wanted to add in, like how you want them to come to you or anything?
Tasks. I guess the only specifics I would have is I mean, it would just, it's fine if you just copy and paste like how you usually write them, like about like a, like I guess like the specific and like around what time you want them to come in. And labs, if we're no longer doing the sheets, I want to know if it'd be possible to just write like a quick list of the specific labs you want them to have, just so I can like rearrange quickly. But if not, I'll work it out.
yeah, the specific labs is rather
Mhm.
important because sometimes providers just write, return in 3 months for labs. You don't want the whole panel, but maybe you're just following their A1C or their lipids.
Just so I know if we need to, if we need them to fast or not. So when we text them, and whatnot. Mhm.
Okay, and Lacey, can you demonstrate the messaging feature too in the EHR? So I've actually messaged providers a few times when I follow up the labs just to say like the hemoglobin A1C is trending up or, they're a little bit anemic. So you can message anybody in the clinic. Everybody's name is in there.
Yeah, I think this will be particularly useful. Like it happens a lot that people want, they have questions for other providers, right? Like, hey Meredith, so and so has a weird rash. Can you look at it or whatever, Um, so it's kind of a similar process. So I'm going to go to charts, and if I'm at Bob's chart again, again, that action up here in the top right, if I click on that, I can go down to send message. It looks like it's the last one that comes up. Do you guys see that? It says for this patient. And then all the way down the bottom of that little box, it says send message.
Mhm.
Yeah. I click that. And then it comes up with a little message box. And so say I want to send it to Meredith. In the search here, would click it. And then it comes up with our providers. I can choose Meredith. It already has the patient. And then it has this nice feature it will keep it in the chart. So it'll keep a record that I'm asking the question in the patient's chart. And so I could just say like, question about rash and can you help blah, 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 blah. And then I can mark it as urgent if it's something really important, and I can send it. So then if I go down, if I'm in the patient's chart, right below encounters, it's got the messages. So, I gotta reload the page. Sorry. Reload. So the next time that I would go to that patient's chart, again, if I go down below encounters, it's right there. So can you help blah, blah, blah about the rash? And it's today's date. So it keeps record too, which is nice. So like if I can think about when did I ask so-and-so to help me out with that, like I can look at my records. And then on the left, if I'm Meredith, or whoever I'm sending the message to, on the left, I've got messages right there. I can go to my messages, and then all of my messages are going to go show here. If they're marked urgent, they have a little orange thing. If they're not, they don't have an orange thing. So, and I would just click on the message, and it kind of shows like an email.
Hmm.
Yeah. And I know who it's from, because it says on the left, it says appointment desk. I was sending the messages from there, and I know it's about this patient. And then here's the message.
Mm-hmm.
Any questions?
Lacey,
Yeah.
yeah, Lacey, would we ever do that when we're seeing the rash at that time, that night, and we know Meredith is in another room?
Exactly. And I
If
mean,
we
and then
put it
she
in
might
there,
image
but
patient.
because sometimes that's when you want to do like a quick consult, if the other person has time, but
I'm not sure if it would appear, if it would come like onto Meredith's screen, like, or she would just have to notice that messages went up to 2 instead of 1. I think we'll have to play around with it. There's other EHRs where the message comes into the bottom of this, whatever screen you're on.
Mm.
And if
oh,
Meredith-
that would be good.
Yeah, if she's not on,
Yeah,
it, she's like, doing a physical or something. she's-
right. And then, if, 5 minutes, I can do a hallway, consult, something quick.
Right.
Sometimes, yeah.
Yeah, it doesn't appear that they like pop up like that. I think you sort of have to like reload the page for them to, yeah, so she'd have to see her numbers have gone up. So
Right.
it might be like a more longer term thing.
Yeah,
But it's still a
yeah.
feature.
There's no way to set that up that the system can send an email like to your personal email. Like if, say, someone's only logging into the system twice a month, then they wouldn't know that it was there. But I don't suppose that there is a way right now with it.
Yeah.
That's a good question. I know you can do referrals on Practice Fusion. I just figured this out today. And it sends like an email. So, I mean, I guess if you didn't want to just use your own
Or a
email.
text message.
Mhm. We can look into that though, Kimberly.
Okay, and has everybody figured out that Carissa's at the desk at the top of the steps doing future appointments with the patient before they leave? Did anybody notice?
Yeah, I think you mentioned it, but
So basically, I think you'll be able to see your schedules, in the future in the EHR. So you'll know, you'll be able to see who's coming back like in advance, which will be nice. And Carissa, any advice or anything about that?
I just have a,
Um,
I'm sorry, Carissa.
no,
Go
go
ahead.
ahead, go ahead. I'm
I
okay.
just have a question about the message and immunizations, because oftentimes the practitioner will send the patient back for an immunization after they've seen them.
Yeah.
And I imagine in the message, it will say what type of immunization they'd like to have. But we may not be alert to the message. If the patient just comes back,
right.
we're going to have to start looking for the messages, I assume. Normally, it's right on the front of the chart what they need.
Oh, so immunizations. I've started doing it again, but normally we used to do it all the time, but I've started doing it again, and I'm gonna make sure like all the kids, if they end up, I'm not sure if they're ever gonna have to schedule this again, but whenever you make an appointment, there's a notes section in the appointment chart. So I've been starting like marking like what labs they're getting, if there's fasting or non-fasting, and if they need like EKGs or like any immunizations they need that night of.
The night that they're
So-
already there.
Yeah, that they're scheduled, or any day that they're scheduled. So immunizations should be listed. So instead of like the sheet in the front, it should be in the notes, like when you open up like our regular appointments chart, like as usual, right next to their name and the time that they come in the notes section. It'll just come up as a list, and there should be like all the immunizations listed for you.
Okay. A lot of times the practitioner will add to that,
Yeah,
Yeah.
and so it would still come
in
as a task.
particular in regard to immunizations.
It would still
Sure.
come as a task to Carissa, and she
Mhm.
would see that the provider wants the immunization that evening, and then
Uh-huh.
she could update what she's saying. She would update their
The
the
note.
schedule.
Yeah. I can
Yeah.
update the note as well.
Mhm.
And so then
We'll
you would
work it out. Yeah.
So on that vein, can I ask a question of the providers? I wondered if everyone would be comfortable with us writing standing orders for the nursing students to give the flu vaccine to any patient that wants it before the provider sees them. What do you guys think about that? Because we know nobody's had the flu shot and, you know, we should be offering it. And if that's the only vaccine they were getting, it would be more time efficient. I suppose if the provider noticed that they needed another vaccine during the visit, then they would be immunized kind of like on 2 separate times.
Mhm.
I think
But
that's
that
fine
would be,
though. To
I
have a
think
standing
that would
order.
be fine with me, Kathleen. Because even if they said no, maybe we'd be able to kind of mention it again before they left. But I think standing orders for flu
Or flu. What about other
probably
vaccines?
have more people getting the flu shot.
What do other people think about other vaccines?
I feel like it would make sense to have standing orders for our TDAPs. Obviously, like for new patients, a lot of times we don't have records for them. And so if we don't have records and they're willing to do it, I'll start the series again. The hepatitis, I always run the panel to see if they've been immunized in the past or not. Most of the time, it's very few patients I've had who come back reactive. I've had a couple, but not many. So I don't know if, like for new patients, if we'd want to, I'd be fine with having standing orders based on their hepatitis panels. But I don't know how time efficient that would be, since they have to come back for me to go through labs with them anyways. And then I usually order them to start the series.
Mhm.
But I think it probably makes sense to have standing orders for almost all of the vaccines with appropriate parameters.
Right. I was thinking of, first of all, getting us linked in with Filovax also, which may help us with the vaccine records, possibly.
Great.
Number one. Number two, maybe using the medical school students to do vaccine audits to determine what vaccines our patients need, to kind of like guide the provider and the patient in that direction, like by age, you need pneumococcal. Have you ever had it? And then, the provider would know what vaccines the person was due for by age and maybe by looking at the history, and then could offer them during the visit. So maybe we want.
I think that's good. I think the only thing is, I want to make sure that one of the important experiences that the student nurses have is giving the immunizations. So I don't want to do double duty with the medical students as far as the assessment. Wondering, because we try to keep the assessments quick so that they're not holding up the practitioners.
Mhm.
Just once we start getting the data in the immunization record, that'll really be helpful. And maybe linking it with, what did you call it?
Filovax.
Filovax, that could be really helpful. But I just want to remind, because we'll have 2 faculty from throughout the fall and winter, that, the students, it's probably one of the few times the students are able to give IM injections. They don't give them in the hospitals. So it's really only at the community that they get to have IM injection experience. So that's just an important piece.
Yeah, I wasn't thinking that the medical school students would give them, but they would maybe pre-audit the chart.
Oh, pre-audit the chart. Mhm,
Audit to figure out what
Mhm.
that patient might need.
mhm.
Just kind of an easy project. Well,
Right.
vaccines are never, but like a project that they could work on before even the visit and make a little
Right.
note somewhere in the patient's chart, you know.
Check for.
Yeah.
Yeah. Okay, that sounds great. Yeah. I saw you note, you said something about the RSV too. Are we going to be giving that as well?
Yeah, is that available in VFAR, Lacey, do you know?
This is a good question. We'll have to talk about it separate, Patty. I'm not really sure.
Yeah.
I think so, but we haven't ordered it in the recent past.
Okay, it hasn't been recommended. It's really kind of just getting out there. So we'll hope to be able to get it. And I will let you all know what vaccines we have, when we have them, and if we're out of stock. I hope to try to keep people informed by their email, especially since not everybody's there every week. So I hope to do a lot of that kind of communication. And, you know, in reverse, hopefully if we're out of anything, people will just email them, just let me know. So I'm coming up with inventory systems also, but you know, supplies that I may not recognize you need, just email me and I'll work on it. Okay, so everybody seems pretty good with standing orders, at least for flu and Tdap, and maybe we'll work other vaccines in as we get better at this. Is that a consensus?
Yeah.
That sounds
Well,
great.
COVID.
Oh, and COVID, yeah.
Oh, and COVID, of course, yes. Okay. Also, I pre-asked Kathleen Bieber. She was fine with standing orders too. So, okay, now the next thing is, could we agree on what would be a standard panel of labs that we get on initial patients so that we all, like, we know when someone is coming for labs, they're coming for CBC with diff, CMP, hemoglobin A1C, lipid panel, TS.
There are, Patty, there is in the room, in each of the provider rooms, I think, there is a list of all the, it's like got like new patient labs, which, I mean, it's pretty extensive, right? It's, well, I happen to, it's CBC, CMP, TSH, hemoglobin A1C, lipids, and the HEP panels, and then, and Hep C if they're over 50. Am I
Okay.
missing anything, anyone? I feel like it's a lot
I
when I
think
read
we
it.
can do a urinalysis too.
Yeah, I don't know if that's standard for all patients though.
That's
All
not,
new patients, I mean.
and it's not on the list. At least the list that I've seen, that's in the nurse's office, didn't have a urinalysis on it. Are you thinking of a dipstick or actual urinalysis, Kathleen?
The actual urinalysis, I guess.
We can get urine out.
Can
Yeah.
we?
Mhm.
Okay. So others, do you agree that we should do a urinalysis on every initial patient?
I mean, that feels a little bit like overkill to me.
Well, really, the one thing I would be protein, but blood, protein.
That's true. I mean, if the
We
patient
could
had a
do
history
that
of
with, we did it in the past in a dip. I guess it depends on the cost too. I don't do it on all patients, but here and there I do, and it has gone through.
oh yeah, definitely. Like for patients with like, you know, uncontrolled
UTI, if you will.
hypertension. Yeah, UTI, definitely would do it. I just don't know that I would do it standard for every new patient.
Right, that's the way I do it here and there, but it does go through.
Okay, and Kathleen Beaver had wanted a magnesium level. She thought a lot of people were low in magnesium. She thought that should be standard on all new patients. Does that make sense to other providers?
Is that more for Kathleen? Is that would be for cardiac, for your risk for, I'm trying to think of magnesium. I don't use it that much, but maybe,
Yeah, I would say don't routinely order magnesium. Like not for a new patient unless there was like a medication they were on.
right.
I'm not opposed to it. I just
I mean, we could make it provider specific, but I think it would be easier if we had a standard list. So it sounds like we agree on most of the standard list, including the hepatitis panel. Magnesium might be like a specific provider's request, and a urinalysis might be specific to the provider.
yeah, I would say that. Yeah.
Okay. Okay. Along with labs, I could use a little guidance on when you would want to be notified immediately on certain parameters, like, are we talking about a new hemoglobin A1C of 9 or 10? Or, I don't know how often everybody checks their labs, so I just don't want to bother people if they don't plan to do anything about it right away.
Yeah.
That I want, I just kind of need a little guidance on that. Like if somebody's hemoglobin is 9, would you want to know? 7, you would definitely want to know, right?
Right. It depends how soon they're coming back. And maybe we should have a system where it's generally like 6 months, maybe 3 months. So you wouldn't want somebody to wait if it's a new a change in the CBC.
Yeah, I mean, honestly, I think for a hemoglobin, anything less than 9, genuinely, I sort of feel like anything less than 10, I'd want to know about. I mean, obviously, yeah, like we're not thinking of transfusing them, but I think most of our patients, if you think about it, I mean, there might be a few patients here and there where I might know, oh, that they typically run low, and that's a well-known problem. Because I feel like that would be a big change for most of my patients. And I think I'd be worried. I would want to sort of have a heads up on that. I mean, I think probably the major labs I'm trying to think about the major labs we're thinking about, probably a WBC, hemoglobin, potassium.
Yeah, and probably if unexpectedly an A1C came back with like a 9 and you
Yeah.
hadn't knew or something, that would be something you'd want to get started on a medication, probably even 8.
Right.
And would you want to be emailed to your
That
personal
would be,
email?
for me, that would be fine.
Yeah, I think email would work. I mean, if it's something really critical, like I think, if it's a hemoglobin, less than 8 or,
Right.
if it's something where you think I would, like this is a question of sending the patient to the hospital. Yeah.
Okay, I mean, that gives me some guidelines.
Yeah, Patty, would you want us to like sit down and try to work up a list? 'Cause I do realize too that like adults, what we consider critical values might be different than peds. I'm not super familiar with peds, but I'm guessing.
Yeah, I mean, I could write a list and potentially send it out to all providers and see if anybody has more like specific parameters or would want to be notified at a earlier, a higher level or a lower level. Maybe that would be the best way to go. Like
Yeah.
I could propose a list and then,
Mhm.
if people have a problem with that, I would know. I would know.
Yeah, I think that would be great.
All right, let me try that. I'll propose a list with some of the numbers that you just threw out for some of the different labs, and then we can go on from there.
I think that's a good idea too. Be
Yeah.
like,
I-
standards that we have.
Yeah, I also would say, like, I think most of us, definitely myself, I'd rather, if you're anxious or, if you've got any question, I'd rather, I don't really see there being a problem with you reaching out. I'd rather sort of you reach out and have me be like, oh, nope, like, as expected, like, I'm okay. Then, like, I feel like if you're worried about something, give a shout.
Okay, so maybe I'll overdo it for a while till I get used to you all.
Absolutely.
Okay. And just a question, do all providers like having labs drawn before they initially see the patient? And then there's the issue of should the patient be fasting, and if so, for how long?
I personally like to have, I mean, I would love to have my labs drawn before I see the patient for the first time. I think that's super helpful. I will say I generally don't ask my patients to fast. The only reason I would ask my patients to fast is if their triglycerides came back funky and I wanted to like double check that it was correct. That's really the only. I mean, that really requires them to eat, I think, a pretty heavy fat load before they get tested. So if they've eaten McDonald's right before, like, yeah, it's gonna throw it off. But I generally tell my patients they don't need to fast before they draw lipids because it isn't really recommended in the guidelines anymore. And I haven't had too many cases where it's been a problem.
Yeah,
I
I
just
agree.
feel
I think that's Amanda. No, it's Meredith. I read a little bit today. I had time, and it does seem like people aren't doing the, fast from midnight, especially the patients we have are working. I mean, we're open in the evening. That would really be tough. It is really tough. So I started to do less fasting. If triglycerides come back really, really high, then, I don't know. It's what I've read is that it doesn't make too much difference. The fasting, is going by the wayside. And a study showed that there really didn't matter much with the cholesterol, LDL, LDA, but maybe triglycerides may have raised it a little bit if they didn't fast. And then I've heard some cardiologists saying 4 hours, but that's not much. So I think we could do away with it.
Okay, one patient didn't come in for his lab visit because he had forgotten to fast. And then that made his first visit be way delayed because his provider wasn't in, for another couple weeks or a month. And so, if we could relax on the fasting, and especially because it is an evening clinic, it seems hard to have people fasting the whole day to not have their blood drawn until 5 p.m. Okay, so you guys are for that, but other providers may feel differently. Okay. So would anybody miss paper charts if we no longer had them? So in my mind, what's in the paper chart is lab results. and that's already been scanned as a document in the patient's electronic record. And there's demographic data, which is already in the patient's chart. There is social history and family history in the paper charts that may not be in the electronic chart. But I would again maybe utilize some medical school students to catch us up and to make sure all that information gets into the charts if we didn't pass the paper charts around.
That would be a help.
Meredith?
Yeah, I agree. I think the only issue that I can see is that sometimes, I do, it is easier for me potentially to photocopy the lab results for patients. Sorry, if they ask for a result, but I assume we could just ask someone to print if we needed to.
Right, or they would be available in the chart if you needed them. I don't know how much you guys look at the paper charts or if it's just a mechanism for carrying around the post-visit papers. But if we're tasking post-visit, making future appointments through tasks, like, do we need to carry around so much paper?
And as far as like giving patients a copy of the lab results, if you wanted to, you guys can print from any of your computers. They're set up like that. So you could just hit print on the labs and then send either an interpreter or somebody down to go grab the labs and they'll be ready for you. So we have that capability.
That sounds great.
Okay, so if nobody else protests the paper charts, we'll hereby declare the paper charts stay in the files and we won't be passing them all around. Okay. Oh, I wanted to find out also who wants to have a scribe, who doesn't ever want a scribe. How can I best train scribes? Just kind of getting a feeling about the scribing issues.
Hi, everybody. I made it on eventually. But I do not find scribes to be that helpful. So I'm happy to have people come observe, and any of that, but I prefer to do my own documenting. It helps me process.
Okay.
Well, the Villanova nursing students, I think it's best if they just are involved. If I can ask them a question or two, or do they have any questions about the patient that I'm seeing at that time? And maybe looking things up for me. And I don't know the legality of them, scribing. So no for the Villanova students, and the medical students really don't have the expertise. So maybe if I don't know. I think it's probably best for us to do the SOAP note. Then, is it a good learning experience when if they can ask questions, the medical students, and learn without, they can look up, vital signs and medications or that are in there. They can see and look up maybe a pharmacy that's close, and check GoodRx for the better discounts. So in that way, we could keep them involved in the case for the plan. But
What
I
if,
agree not
what if they were better trained?
scribing.
What if they were better trained, Kathleen? What would you think?
Oh, for the medical students, well, they would then, I go over it. Some of the medical students, especially the ones that have had other experience, like working in research or doing notes, some have better skills, but it's not uniform. No, I'd have to, for soap notes, put, but I can't see them still then doing the whole note. We'd have to repeat it and say, write this. And then what about abbreviations and things of that nature? Might be too much, but to look up immunizations and, switch screens on the EMR to be helpful, but I don't know. What does anybody else think? I'm really maybe residents, but well, then they'd want to do the whole note probably. But right now, I'd have to think about it. Maybe
Okay.
what would it take for them, and what would be the limitations?
Okay. Good input. Another question is that there has been a potential brand new provider who might want to volunteer at the Unity Clinic. And I kind of wanted to pick your brains and get your thoughts on, has that ever happened before? So this person was educated, has been a nurse for a while, but has never worked as an NP over the last year. I think she graduated in 2022. And I just wanted to see what you guys got in terms of a brand new provider, how much support they might need, and if that's ever happened before, and what you all think.
I can't
Can
remember.
I,
Oh, go for it.
I'm sorry. Wasn't Amanda a brand new NP? I think she really came because she had no, she was pregnant with the twins, or just had the twins, but she was just out of school. I think she spent time being mentored. Do you remember, Meredith?
Yeah, so Amanda, she was pretty new. And so she spent a couple months with me. And then I'm on call for her, for any issues. So I mean, I think it depends provider to provider, right? I'm happy to have someone with me. And I can, plan to be more intensively either in the center or available via telehealth for them. I think it would be a good idea if they would shadow a provider, somebody, myself or somebody else. Sorry, lots of kids in the background. For like for a month, maybe, to get a sense of really of just our typical patient population and what things look like, what we have available, and the flow of things. And then for them also to kind of get a sense of what they might need. Because I think it could be really different person to person. Not sure how comfortable they felt into what support they might need.
Was Amanda working elsewhere as an NP when she was also volunteering as an NP? No.
Not initially, no. We were her first site initially.
Okay.
She is now.
Okay. Okay. All right.
I think we all had to start out some,
Yeah.
after we graduated, and we did get positions, but maybe recognize that mentoring is good, for a month or so, or having them work with one of us and
Okay. All right. Then I think what I'll do is have her come in and observe how the clinic is and see what she thinks about it. And I haven't actually met her yet, so that's a good go ahead. The other thing I wanted to ask is, so now that Carissa is doing future appointments, it's really helpful to know providers' schedules, like at least maybe 3 or 4 months in advance. And I wondered what the best way is to keep on top of your schedules. I know everybody has times when they normally come in, but could you, like, should I email all providers and say, can you flesh out your schedule for the next, from now till January? And if it changes, it changes. Everybody understands that. But I was just trying to get it more so that Carissa knows exactly when you'll be there. Appointments, that's efficient. Is 4 months in advance too far?
That works for me.
Okay.
It's okay for me. But
Yeah, I can do that
with
too.
younger, I'm just thinking about those of us that have little children. But as you said, there are things that come up that you can't anticipate, with everyone. So
But then patients could be rescheduled. So that's easier than, trying to keep track of it outside of the EHR and, trying to figure out when people could be scheduled. Okay. Does everyone know the mammogram van is scheduled for December 15th? And we have, thank you, Lacey. Go, Lacey. We have about 30 people on the list that need mammograms, and they can only take 16. So we are be hopeful that another mammogram van date can be scheduled soon after the December 15th. So I'm working on a mechanism where I just write out what they need written on the prescription, and you guys just sign it for all the patients that you've referred, and then we just keep it. So I collected up the numerous mammogram scripts that are kind of like floating around. But I'm just gonna try to standardize that so that it happens efficiently. And the other thing I wanted to just tell everyone is I've gathered the emergency medications and equipment into the room where intake is. So the AED has been moved out of Kathleen's room. There's Narcan now in that closet. There's injectable Benadryl. There's oral Benadryl. We're working on getting epinephrine. I don't know if anybody has an inexpensive way to get epinephrine that we could buy it. It's about $250 on our medical supply place. So I don't know if anybody has any ideas of how we can get epi. What we have right now is expired. So we thought of writing a prescription for Lacey through GoodRx where it's cheaper, but then there's kind of ethical dilemmas with that because Lacey is not anaphylactic. Any ideas?
Patty, I thought that the public health department provided the epinephrine. When you go on large group things, they always provided it. I see the nose.
I don't think so.
No?
I've never seen that happen.
Every
They always
time
tell
I've
us
done a
that.
large thing with COVID or something, they always provide, some epinephrine.
Just for that outreach or
Right.
to keep? Yeah, I think we're giving vaccines in the clinic, so we really need our own. Okay, so we might just have to bite the bullet and buy it. We're also working on a new battery for the AED. It probably has enough battery for one shock, maybe. Hopefully we never have to use it, but Lacey's working on that. But I just want everybody to know all the stuff is there, and that's where you access it. There's albuterol in there, there's a working nebulizer, there's tubing. So that's where it is. Okay.
Thanks, good.
The other thing is, I think everybody here knows this, but just of note is for us to get a patient a colonoscopy at the surgical center, we first have to have a positive FIT test. So the first step is somebody, especially that's symptomatic, needs to do a FIT test. So I don't know, Betty, if our nursing students could educate patients on how that happens, how that occurs, and how to do it.
We had a demonstration with Lacey, but it was pretty quick. I'm not even sure I could redo it. So we need to know more about it and how to go about it, I think.
Okay.
I could come in early, Betty, and do that with the students. The FIT test.
Say that again, Kathleen.
Oh. I could go over the FIT test with some students from Villanova if they came in early, or
Right.
don't
Well,
know if
I
we
just
could-
need, I mean, we just did it once. So, and that was a month or so ago. So I would just want to do it again.
This is the
No.
poop test, Betty.
The what? The poop?
Poop test.
Did you just say poop?
Mm-hmm. I don't know if I've gone over this with you.
Yeah, somebody did. Maybe Michael.
Michael did.
I think Michael did it. Yeah.
Got it.
And it was pretty quick. So, and I guess we would need to know when we would do that, like that would come in through a message or.
Yeah, that would be in a task that would happen when the patient was there in the clinic.
Uh-huh.
And, then the test is taken home and then they bring it back later.
Right. It's not difficult. I mean, it's just a matter of remembering,
All right, so we can work on that. Okay, and then the other item, Amanda had wanted to talk about what we do with patients when they're beyond our scope. So I don't know if you more experienced providers have wisdom, or is that a case by case thing?
Right, it is case by case. I mean, I've even asked Amanda, and I shouldn't say even Amanda, I've asked Amanda, it's, or Meredith. And do we still have cardiology, Lacey? Do we still have a cardiologist?
Yes.
If we can call him, is okay. And is he there for consultations as well? But everybody's not.
Is she freezing for everybody else too?
Our decision, like blood pressure, very, very high. I guess we could maybe have something written up on. If it's such and such, maybe it means the ER.
Or the health district center if it's a involved chronic problem.
Right. I'll just say for some diabetes, if it's not something that because we don't have too many medications. Well, we have a few, for, of course, for type 2 diabetes, but some of our patients, a couple have needed more, like the injectables, the newer classes that the health center can help with at really affordable prices, and we can't do that. So I have told patients that that would be the best thing for them, and that was for diabetes. So or bringing them back sooner, having someone call them or myself call during the week. That doesn't happen often, but something we can do. But maybe maybe there should be, well, usually because everybody's not there the same night. But and it is hard to send to the ER because you're not sure the patients are going to go. So that is something, issues beyond our scope. You know, sometimes you do have to ask them, you tell them the best treatment would be to go to the health center. You know, I like the fact that we can use the surgery center for some derm problems, and I wasn't thinking of using my camera to take pictures of some rashes too, and send them, or maybe a mole, something we don't like. We could actually even send that, I guess, a picture to the surgery center because they do dermatologic, you know, surgery, not per se, not a rash, but that is something that maybe we have to talk a little more, the scope. We have, you know, the ER or the health center, unless we have a social worker that gets insurance somehow. But with that being said, maybe somebody could be available by phone on a given time. But it's our best judgment, really.
Okay, so to continue to be discussed and thought about.
Mhm.
Yeah, I think it's pretty difficult to create blanket statements about when patients are, beyond their scope of practice, because there can, I do think a lot of times it is a judgment call. I do think if there's a patient that, there are definitely patients that I know, they're coming in with chest pain, and we have we have had patients who have come in. We had one patient who's coming in experiencing a heart attack, like clearly needs to go to the ER. There's no options about it. There are other patients though that, I've discussed, like maybe called a cardiologist and said like, hey, here are the symptoms, here's what's going on. Is this worrisome? Can this, wait and be seen in the office, or, talk to Kathleen about, because I do start to say it is a little like, say you've got a patient with like a high blood pressure, like it is sometimes really dependent on like, well, but like, are they symptomatic? Are they not symptomatic? Do they have a history of high blood pressure? Like there's a lot of, it's really hard, I think, to create blanket statements around. I mean, there's some things that like we could say like are definitely out of our scope of practice, but there's a lot of other cases I think where we see it's a little bit more gray areas and judgment call. So yeah, probably something maybe for further discussion.
Okay, so as we bring on new providers, that kind of guidance would be somewhat helpful. I would kind of like to create a little like guidance sheet for new providers that come to join us. So I'm starting to take notes now.
Yeah, thank you for that.
Okay, does anybody else have anything they want to bring up that we haven't covered or that you're unclear about?
Sorry, I muted and then unmuted. I was wondering about when you say out of the scope of practice, I mean, there's a lot of things that we can't do, like eye care, and things like that. I was wondering if there, as that list you're talking about, if there could be resources that the providers might have. So if somebody they suspected had glaucoma, where can we send them? That type of thing, you know, and generate those kinds of lists.
It
Yeah,
would be like a referral list, you know,
Yes,
to,
we need to
yes,
some of our resources to research things like that. You know, maybe Lacey was talking about a pen service club. What are they called? That does that kind of thing. But we need to let them know what we need them to research.
So
oh,
that would be great.
a couple of things. One, there is a document that was distributed to all of the providers in 2021, so it does need to be updated. I sent that to you today, Patty. With where to refer people when. But we'll update that for sure. And then yes, Patty's right, Service Link. Do you guys remember them? They'll be coming, and we think we're gonna have them come once a month and then be accessible by phone or email or Zoom, something like that, virtually. And you'll be able to ask them questions. So we'll have a list like of where to go for optometry or things like that. But if there's anything else that comes up, everything from optometry or dentistry to housing and security, English classes, I mean, whatever kind of social.
That sounds great.
Yeah.
Lacey, who, if we need PAPs for a patient, will we still be sending them to Jefferson?
Yeah, so you would put that in your task, and
Okay.
then Carissa or Patty Carissa will make sure Patty gets it, basically.
Okay.
Anything else anybody wants to bring up? All right. Well, thank you all again for your time, and I hope the others that weren't able to be part of the meeting are able to listen. I'll write up some stuff. I'll be sending you some stuff, and we'll move forward. So I guess it would be nice if we could kind of like touch base maybe every 5th Tuesday, which I think happens 3 or 4 times a year, to try to, you know, keep on task and keep a group consensus and a group sort of dynamic going on. So that would be my goal. Okay, well, everybody go take care of your children and your pets and your hungry people that might not have had dinner yet. And thank you for your time, and I'll see you around the Unity Clinic.